The unicompartment surgery has its place in history as one that has waxed and waned in terms of popularity, but is now a well-established procedure for the treatment of the unicompartment disease. These are my disclosures that have no bearing on this presentation. Of options available, there is a whole plethora of options available: fixed bearing, mobile bearing, all poly, and various companies have their own prototypes available in the market. These are some of the common varieties that have been used: the metal bag, the all poly. We have in particular been using the Zook and the Persona designed implants in our own practice. The fundamental important ingredient for a good outcome is proper patient selection, and I cannot overemphasize this. The deformity has to be fully correctable, and uncorrectable or a fixed deformity does not lend itself to unicompartment surgery. In terms of the ideal indications, it should be unicompartment in its etiology, affection, varus, and valgus deformity less than 10 degrees. It must always be degenerative. Some amount of patellofemoral changes are acceptable. When Dick Scott introduced this concept in 88, 89, he had this criteria of body weight less than 85. He redefined this and has now extended this body weight indication grams. There should be no subluxation, and it is integral that the ACL is intact. The contraindications include inflammatory allergy, rheumatoids, for instance. There should be deformity greater than 10 angular deformities. ACL deficiency in the young active patient indication, as is the lateral thrust and severe patellofemoral, particularly lateral facet osteoarthritis degeneration. So the ideal encompass an X-ray that looks something like this: a straight opening of the medial compartment, which indicates the collapse as a cartilage loss and bone-on-bone contact. Some amount of lateral changes are acceptable, and these lend themselves to good indications for a surgery. The advantages include a low morbidity, a rapid recovery, and since we do not dislocate the patella, the quartz recovery is quick. There's almost negligible bone loss, and the hospital cost and hospital stays are minimal. Of subsequent revisions, the revisions are usually relatively simple and can be in primary components. The ideal indication of unicompartment surgery is, and this is where this differs from a total injury, to undercorrect the deformity caused by overcorrect, transferring the stresses to the opposite compartment, accelerating change. Leave the joint 2 millimeters lax and 90 degrees of flexion. It's absolutely critical to understand that unicompartment is not a half-knee replacement. And by reducing the tibial slope and ensuring that you get a deeper cut anteriorly than posteriorly, you equalize the flexion and the extension gaps. In terms of the evaluation, you need to evaluate the patients for the HSS scores, the knee society scores, and the radiograph and the Oxford scores. Of evaluating preoperatively, you need to understand how to align the tibiofemoral component. You have to look for radiolucent lines, which may be benign or may be indicative of initial loosening and progression of loosening, and finally progression of arthritis. I think these are the critical ingredients when we evaluate these patients at our post-operative evaluation. This is the point that I made earlier. By decreasing the slope, you tighten up the flexion gap and you're able to align your tibial component, which is a critical ingredient for successful performance of a unicompartment surgery. The other indication, which is very important, is to understand that the femoral condyles have divergent angles of almost about 18 degrees, and you do not follow this divergent angulation. In fact, you actually aligns to the cut tibial surface, and this is one of the commonest mistakes that is performed by people who are starting to do unicompartment surgery, and I cannot overemphasize the point. A radiological evaluation would show and correction on the and right is really an overcorrected design, and this is more akin to a total knee replacement, and this will transfer loads to the lateral side and encourage lateral osteoarthritis. This is a step-by-step measured resection of the total of the unicompartment, just an account of this procedure. So the tips and pearls align the femoral component at right angles to the long axis of the resected surface, prevent a varus tibial cut, use minimal resection of the tibial bone, always protect the ACL when making your sagittal tibial cut, and prevent undercutting of the eminence. Prevent stress rises at the proximal part of the femoral resected surface, prevent impingement, and leave your knee 2 millimeter lax on the side of the deformity. This is a perfect alignment and will stand the test of time. There are obviously several things that can go wrong, bad procedures. This is a poorly performed knee that failed very, very rapidly. You can see that the alignment and the positioning of the femoral component is completely wrong. Fractures are not uncommon, particularly when you don't protect the sagittal saw blade cut, and this can lead to collapse of your tibial component. And in the event of this happening, this lends itself to revision surgery and usually will need some sort of a stemmed implant and some form of constraint. The other reason for revising knees is progression of osteoarthritis, and typically in terms of progression, if it's done badly, you'll have lateral progression at a mean period of about 53 months, and patellofemoral changes happen much more rapidly. Polyethylene wear typically takes anything from 8 to 10 years. These are examples of osteoarthritis progression because of a tight medial compartment necessitating revision. This is a very interesting patient that we had where the femoral component was actually put back to front and needless to say, failed very rapidly. Revisions are usually relatively easy and you can use primary components with or without stem augmentation to achieve a good balanced knee. This is one of our patients is 16 years doing well using a fixed pairing cemented option. When you look at a review of literature, these are the very initial data from Scott's database, 82% at 11 years, Rich Berger's and review at 2005, 13 years, 95.7%, excellent results that he reported. Sebastian Parrott from John Noel Arjunsen's group, reporting 12-year survivorship of 80.6%, and several other reviews of literature using different types of modalities, all poly showing 87.6% at 10 years, the Oxford 90.6% at 15 years, and a comparative cohort of unis and totals where the uni cohort reported better patient-reported outcomes and functional scores in an article in 2016. Some other reviews of literature, more recent literatures, 90% survivorship at 10 years. Scott redefined his outcomes and reported BMI greater than 30 and age less than 65 as significant risk factors. And in a meta-analysis of 8,658 knees greater than 10-year follow-up, reported 10 and 15-year survivorship of 93 and 89% respectively. I'd like to thank you for your kind attention.